Thank you, Constantin. Thank you, Leonidas. It's a pleasure to be here and to take part to this panel. So the topic is OCTA really useful for diabetic retinopathy to see something better than fluorescein angiography, or something that we cannot see using other methodology? In order to try to understand if there is any utility for OCTA, we'll try to consider some of the most important aspects of diabetic retinopathy that we usually consider clinically. The enlargement of the foveal avascular zone, capillary abnormalities, capillary non-perfusion, microaneurysms, intraretinal microvascular abnormalities, and new vessels. So starting from the enlargement of the foveal avascular zone, you know, it's already in the literature some contribution about this topic, and these contributions were able to show that the superficial as well as the deep capillary plexus are showing some kind of enlargement of the foveal avascular zone in diabetic patients with retinopathy. And you can see some microinfarction of the surrounding vascular arcades. And there is also some evidence that there is a relationship between the foveal avascular zone area and the ischemia at the macular level. And there is also a correlation between the foveal avascular zone and visual acuity. And you can for sure better than using fluorescein angiography, measure the amount of ischemia, which is something that we were always trying to do using fluorescein angiography, but unfortunately, quantification of fluorescein angiography was always an unsolved problem for us. But what we were able to show, and this is a contribution from our group, is that sometimes you have an enlargement of the foveal avascular zone in diabetic patients without diabetic retinopathy. So before any kind of evidence of diabetic retinopathy, you can already find something which is showing that the foveal avascular zone is enlarged. And this is also another important contribution that I think we were able to give. You can find some kind of microvascular anomaly when you have no lesion on the structural OCT. So, you know, the main question during these last years was, is some kind of neural degeneration appearing before or after microvascular abnormalities in diabetic patients? So what we were able to show is that microvascular abnormalities were present in patients where you had no structural OCT changes. So considering that, you could imagine that OCTA could be used as some kind of screening program, screening instrument device used for screening program in diabetic patients. So again, we published a paper where we were able to show that the foveal avascular zone size was related to the grade of peripheral ischemia and the level of diabetic retinopathy. But you have also limitations about these kind of measures. The foveal avascular zone is variable. It's completely different in one patient from the other, and you have no database to look for evaluating your specific patients in order to understand if there is something strange or not in that specific case. And you have this kind of variability, which is absolutely important and make any evaluation you do difficult to be measured. And in patients with diabetic retinopathy, sometimes you have the absence of the foveal avascular zone. So there is some anomaly, you are able to see some of them, but many times it's impossible to attribute a value to what you are seeing. And other points are that the segmentation of the superficial capillary layer and the deep capillary layer are difficult to be done. And boundaries are not uniform, so you are many times in trouble to understand what is superficial, what is the deep capillary plexus. And for sure, we need a lot of effort in this direction in order to be able to be sure what we are evaluating. So this is for the foveal vascular zone. Now something about macular edema. You know that there was already some contribution in the literature, and the main aspects of these contributions are summarized here. The segmentation artifacts that you can have are induced by fluid when you have diabetic macular edema. You can have some alteration of the foveal vascular zone profile at the level of deep capillary plexus. The superficial layer is much more easy to be quantified, and the deep capillary plexus disruption is a predictor for a poor response to anti-VEGF therapies. What about capillary non-perfusion? Capillary non-perfusion maybe is the best thing that we are able to see using OCTA, but unfortunately at the moment, as you know, you can do it only at the macular area, in the central part of the retina, and we know very well that in diabetic retinopathy, the periphery of the retina is very important for the evolution of retinopathy. You have this kind of capillary non-perfusion information which are not made complicated by leakage. You have the vessels only in any phase, so you do not need to evaluate them only in the very early phase of the angiogram, as we did when fluorescein angiography was the basis for this kind of evaluations. And for sure, at the moment, the only instrument that is able to give you information about the far periphery for 200 degrees, so it's something that it was impossible only some years ago, is this kind of ultra-wide field angiograph, or some kind of lens, contact lens, that are able to guarantee, such the one preferred by Professor Zographos, I know, that are lenses able to give you, with one shot, a very important, very high quality evaluation of the periphery of the retina. With reference to microaneurysms, they are dilation of capillaries, as you know very well, and sometimes you can see them on OCTA, well, such as on fluorescein angiograms, without leakage again, but many times on the basis of the speed of the blood inside the dilation, you can have some problem to identify them. And in fact, OCTA is inferior to fluorescein angiography for detection of microaneurysms. And there is a contribution which came from an Italian group, Maria Cristina Paravano in Rome. She was able to show very recently that microaneurysms associated with internal hyporeflectivity are on OCT. They show a lower detection rate on OCT angiograms. OCTA did not provide information on BRB status, for sure, and fluorescein angiography is still needed for focal laser treatment, because only by that it's possible to recognize leaking microaneurysms. A combination between OCTA leakage index and OCTA identified sites of alterations of the BRB. What about new vessels? New vessels, as you know very well, you do not need OCTA to recognize new vessels, but what can we see using that? You can see them very well. You have, again, no problem related to leakage. You can see the shape, the silhouette of new vessels very well using OCTA, and as you can see here, for example. And the other point is that you can see how these new vessels change their shape, their morphology on the basis of the treatment that you are using to produce their regression. Peripheral new vessels, for sure, are not well seen by OCTA, and fluorescein angiography is still needed to differentiate new vessels in active or inactive lesions. And the possible signs on OCTA of new vessels: for the active lesions, you have exuberant vascular proliferation, an irregular proliferation of these vessels, and the inactive form shows new vessels had pruned vascular loops of filamentous new vessels, but not this exuberant vascular proliferation. So in conclusion, OCTA provides useful information in diabetic patients. No question about that. The main limitations is due to the lack of information on peripheral retina, at least at the moment, and the lack of leakage. We have still to learn how OCTA affects the therapeutic decisions in diabetic retinopathy, and I'm sure that advancement in knowledge and technology will overcome most of the current limitations. Thank you very much.